Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes.
In this episode, we take a deeper look at why so many nurses leave the profession during their first year. Dr. Rhiannon Winsor speaks with nurse leader and educator Heidi Sanborn about the realities new nurses face once they enter the workforce. From emotional and physical demands to workplace violence, staffing shortages, and the lingering effects of the COVID-19 pandemic, the challenges can quickly become overwhelming. They also explore the disconnect between classroom education and clinical practice, and why stronger partnerships between academic programs and healthcare organizations are essential. Finally, the conversation turns to leadership and how organizations can better support nurses early in their careers before burnout and disengagement push them out of the profession.
Many nurses don't leave healthcare after decades of work. We've already talked about that. They leave within the first year. What actually happens during that critical first year? And what can health centers do differently to keep nurses from falling through the cracks? Why is that first year such a breaking point, I guess, is my first question.
Yeah, and that's such a difficult question to answer because I don't walk in the shoes of new grad nurses now, but I do hear from a lot of them, and I see conversations that are happening, and in my perspective in academia, I do get a little bit of a finger on the pulse on what some of the nurses in our state at least are saying. And I think these are some common issues. I will say first and foremost, what we can't forget is that this is a very emotionally demanding, physically demanding job for the best of us, even for experienced nurses. I will say there, of course, are a few bad apples in every profession, but for the most part, nurses choose to come into the profession because they want to do good. They want to help their patients. They believe in this idea of, easing pain, providing relief, making that human connection with our patients. And I think that is critically important to remember, because I think the emotional burden of that incentive for a job makes this job particularly demanding and makes it at risk for higher burnout. And so as we see with increased demands of, a physical nature, we have nurses who are seeing increased rates of violence from the community, from patients, from threats from family members. There's just a lot of now, posts on Facebook about, for example, a nursing strike and some of the negativity that comes out. How dare you stand up for yourself in your profession? I'm not taking a stand on nursing strikes, but I'm just saying that nurses in particular, again, by nature of our job of being at the bedside 24/7, we're held captive to that anger that is really rising within our country right now. And it's shocking to me to think that the nursing profession, by the way, another year in a row, over 2 decades of being the most trusted profession in the country, yet we're seeing this increase in violence and threats at the bedside. That is really deeply distressing to me. We see increasing rates of obesity in patients, and that means that the job is really physically demanding for our sickest of patients. We see an increase in the complexity of the type of care that we deliver, more equipment at the bedside, more complex systems that we have to manage, alarms going off constantly, a very loud, chaotic scene in a unit. All of those things are these physical pressures that get pushed onto you. And then through it all, you're just trying to ease suffering. You're just trying to do good for the world. And that is a really that is a very potent recipe for burnout. I think that compassion fatigue, along with just the physical, emotional demands of the job, I do think that has escalated, and I think that's a huge contributor to why we're seeing increased rates of burnout. The stakes are higher, the pressure is more demanding, and it's taking its toll for sure. And we don't have the mechanisms in place for someone to safely say, "Uncle, I need a break. I have to hit the pause button. I need to take a week off of work for mental health." Well, unfortunately, we're short staffed and it's not your turn to get a day off. So if you want to take it, it's going to be unpaid.
Mhm.
That's not a great solution when somebody's telling you I'm burned out and I need help. But that's where we're at. And I think that's, if I could tap on one thing, I think it's that, bundle of emotion that I think is what's creating all that burnout.
Mhm. I spent 12 years at the beginning of my career scrubbing in surgery. And we didn't talk about burnout. We were short staffed. We took a lot of call. I can remember working a 7A to 7P shift, and the 2 to 10 person did not come in. There was a slew of cases that got added on that now became my responsibility after working a 12-hour shift. I had like 3 ankle fractures add on. Here it is, 1 o'clock in the morning, and I'm rushing my tray back to the OR to sterilize it, and the C-arm is coming into the room at the same time, hits me, I drop the tray, and a billion screws go everywhere. And I just sat down on the floor and literally started crying. Like, I was exhausted. The surgeon that I was working with was not the nicest. He was tired too. And then, so I don't know if I was hiding under a rock or what, but in 2018, when I started my doctoral program, one of the first DC cohort meetings I went to, one of the students was presenting her dissertation on burnout. It wasn't in the field of nursing. I think it was occupational therapy or something like that. But I can remember that being the first time that I ever put the two together. And then I think about how COVID was like this wrecking ball through the healthcare system and healthcare professionals in general, but especially nurses.
Yeah, what a traumatic time in our history for anybody even remotely connected to healthcare. And for all of the people who lost loved ones or had to go through the system with themselves or a loved one. There was nobody who wasn't traumatized by the COVID experience.
Yes, and what the training looked like, what the education piece looked like when you were sending, not you, but in general, we were sending baby nurses out without really having done any real patient care. They hadn't touched a human.
And you can understand in hindsight why that happened.
Of
So many
course.
different reasons, but it did such a disservice that I do think, while I think, COVID is behind us and we've moved on, I think some of those implications, those nurses who came out and made it work and are still in the profession, in my opinion, are on a pedestal and always will be for me. What a pressure cooker of an environment to become a new grad with inadequate training for a very human connected profession and to still be here this many years later. Every time I meet one of them, a lot of them now are thinking about coming back for grad programs, and that's where I run into them. And I just am amazed of the resilience that they put into it. And I think, I hate the word resilience because it implies that they're so amazing and other people who maybe weren't as resilient somehow did something wrong. It's just about applauding the people who managed to stick it out because it was a failing situation that they were put in, and they chose to get through it. And I think for the people who did make it through, I think it's because of the human connection. I believe for every single one of those nurses who came out and made it through, it's because somebody on the clinical side, a nurse or otherwise, took them by the hand and said, it's okay, I'm going to help.
Mm-hmm. Mm-hmm. Ooh, that gives me goosebumps to hear you say that. Yeah, I absolutely agree. And so here we are on the other side of COVID. What gaps are you seeing now between the classroom and the field?
Gosh, I could talk forever about this because I sit in meetings and I hear conversations from clinical leadership and academic leadership. And those gaps are always talked about. And quite frankly, on either side of the table, clinical or academic, we will have an idea for why those gaps exist. From the academic side, well, it's because the clinical environment isn't orienting them well enough. We can't do everything. And the clinical side is saying, but they're not prepped well enough when they get to us. They're not able to connect the dots. You're clearly not prepping them to be prepared for a new grad job. I don't think the problem is on either side. For me, I liken it back to what we talked about in terms of innovation and the constant change in healthcare. So when I went to nursing school in the 90s, we wrote notes. I had to learn how to write a note and what did you put in a note, and that was the end of it. Now we have electronic medical records. You have to learn, and the way you speak to other providers isn't in person anymore. You've got to call somebody, wake them up in the middle of the night. So communication is a huge competency. Now, we can certainly discuss the basics of what should maybe be in a note for a patient. The problem is they go into the clinical environment, different EHR systems, different documenting styles, different protocols on how and where they access, where they've got to put their information. Changes constantly about charting by exception, but if you didn't chart it, you didn't do it. And all of those mixed messages that we give new grads, we can prep them in academia for the concept, but there has to be some sort of a tandem training on the clinical side for that specific need, that specific system. We talk about it with EHR, but what about, different equipment that different units have? We talk about the lift equipment. Every unit has a different type of lift equipment. How do they work? How do you attach the sling to the frame of the lift equipment? How do you use a remote? Where is it? How do you charge it? All of those very simple things, different IV pumps, different tubing, that variety of equipment and systems that nurses have to use is always going to be there. We have a free market society. Lots of companies are selling products, software, and equipment for us to use. You can only train so much. Sometimes you have to learn by doing. So we can teach them the concepts behind that equipment, but there has to be that sister treatment and training on the clinical side of how to use that equipment. And I think that, to me, that's where the gap lies. We'll never close that gap. What I think academic and clinical partners have to do more intentionally is work together to identify what is that gap. How is that gap different for every clinical partner to every academic partner? And what specific things could we put in place that we could train those nurses so that when they get out, that gap is just a little bit narrower and maybe less deep?
Yeah, that makes me think about when I started my clinicals as a surgical technologist, and I'm leaving the classroom and I'm thinking, oh my gosh, I learned so much. Like, I know so much. And I get into the operating room and quickly realized that I felt like I didn't know anything at all. Like, did I have an understanding of anatomy and physiology? Yes. Could I identify the instruments and did I know how to pass them? Yes. Did I have an understanding of basic procedures and draping and those kinds of things? Yes. But had I ever seen total knee instrumentation? No. Had I ever worked with, an arthroscopy pump? Like, there's, and then on the flip side of that, working with clinical sites as a program manager, they're like, well, your students are coming out and they don't know how to work an arthroscopy pump. Well, I don't have an arthroscopy pump. Like, the best I can do is have them watch a video and maybe jot down the steps. Some of the things, it's just not possible. The Da Vinci robot, I don't have a Da Vinci robot. I can't get my students experience with that. And So as I started having those conversations with the educators or the OR supervisors or whoever about, hey, like, okay, let's see if we can partner together so that when said student finishes the clinical experience, now they actually do have a better handle on those types of skills. I mean, I think you're right. You're right on the money with that.
Yeah, academic clinical partnerships are absolutely critical and they have to be open. I think when any institution, academic or clinical oriented, when they start to narrow the scope of their partnership, we will only work with this one partner. I think you're doing yourself a disservice because the students that are coming in and training may come from various different academic institutions. And as a school, if we're training our nurses, they're going to go out into this bright world and find jobs all over the country, if not all over the world. We have to start figuring out where they're practicing and how we can close those gaps. And it takes that two-way communication across the aisle to really understand what those needs are. And when we identify gaps, because they'll always be there, how do we work best together to close those, or at least make sure that there's a soft handoff there?
Absolutely. So, because we're an accountable care organization here at VB Care and we're partnered with federally qualified health centers, I'm curious what your thoughts are about how these circumstances are really showing up in community health centers or FQHCs. What are your thoughts?
Yeah, I think when you start to look at any market that is really narrow, meaning there isn't a deep bench of trained nurses coming, for example, to fill your vacancies, or you have a department that maybe has one discipline working multiple, ambiguous types of roles because there's only one person there, versus, you're in a great urban, training facility, a university-based facility. There are so many personnel there, and everybody has a very narrow scope of what they do, but there's always somebody right next to them who can do the other pieces. When you're in a more of a rural community where you don't have that deep bench of staff across disciplines that can handle all of the various things that are going to come up on a daily basis, you have to rely on your people in a very different way. I remember talking to a dear friend of mine who is a nurse practitioner and was talking about training new grad nurses, particularly to work in primary care, both nurses and nurse practitioners. And the problem that they ran into in general was that they would typically fail because there was nobody there in that role already. There might be one vacancy, there might be one NP, for example, there might be one RN ever working in that environment. And so I think that, we have to really think through training and orientation when you get into those kinds of environments, because those roles do become much more ambiguous by default of what they have to do and how few staff are there to be able to do it. It's an all team approach when you're in that environment.
Absolutely. So, what would you say are some early warning signs that a new nurse is either struggling or disengaging on the way out the door?
Yeah, I think that the higher up you go in leadership, the less warning signs there are going to be. Because I think in general, the environment has become so punitive that people tend to keep this stuff close to the vest. And I do think that's where it becomes a community environment. The entire unit and all of the leaders, the frontline charge nurses, we all have to rally together to identify some of those warning signs. And I think there are many. I think that people would think a warning sign is, oh, she's calling in sick. Do we know why this nurse is choosing to call in sick? And I think that's the missed opportunity there. Calling in sick itself isn't a warning sign. How we respond to it becomes the warning sign. Because I think when someone comes to you and says, I can't get childcare on Tuesdays, and I told you I couldn't work on Tuesdays, but I got scheduled every Tuesday this month, I'm going to have to call in sick, or can you help me get off the shift? I'm sorry, the schedule's published. There's nothing I can do. We're short-staffed. You're going to have to make it work. That is the warning sign. We have to do some internal reflection about how we're responding when people are coming to us saying that they need help. And I think that in and of itself makes sense why someone, childcare in and of itself, among anything else, my car broke down, you name it, I can't make rent, I was a victim of domestic violence, whatever the reason is, there are lots of reasons why people might say, hey, you know what, I don't have any sick time left, but I cannot work tomorrow. What can you do to help? And so I think that number one is when someone reaches out and we can't help them, that's the warning sign. I think that's a really important thing for us as leaders to remember, that when we can't help somebody, we're failing them. And if we fail them enough times, they're going to realize they can't count on us and they will go somewhere else. So I think that's a really big point of reflection for us in terms of warning signs. I think in terms of disengaging, I think that's a bigger thing. Do nurses show up and talk about and participate in opportunities to expand their roles? Are they asking about, hey, I want to get certification. Is there any support for me to maybe take the exam? Those types of things, when you don't have nurses who are asking what's next, or if you're not asking your nurses, what's next for you? What do you want that to look like? Again, I guess I'm talking more about missed signals than I am true warning signs. I think the warning signs as leaders, we won't see them. Somebody is just going to magically up and quit. But I think there's been opportunities along the way for us to help them realize the potential of the career they dreamed of having. And we have somehow not noticed it, not heard the need, and we've dropped the ball in some way, shape, or form. Working now is very transactional. And if nurses feel like, particularly new grads, if they can't get out of the profession that long-term fulfillment of what they need, how many of us as leaders ask every one of our staff members on a regular basis, what do the next 3 years look like? What do the next 5 years, 10 years for you? What can I do to help that reality come to be for you? If we're not doing that regular check-in, I think that's that risk of disengagement, because if they feel like they're in a dead-end job, there is no reason to stay.
I know I've definitely felt that before with one company that I worked with, that several times went to them with something that I thought might be innovative, and the response was, that's not the way we do things here. I started to have wandering eyes, I'm not gonna lie. And I think kind of the icing on the cake for me was I had applied for an advanced role, and my supervisor, when I talked to her about it, she said, we can't lose you. So my takeaway from that is like, I'm never gonna move you out of this position because you're good at it and things are going well. And so then that made me think, okay, well, there's no room for advancement, and I want to stretch my wings and fly and learn new things, and that's just innately how I am. And so eventually I quit.
Yeah, and I think that's a perfect story to sort of describe what I'm thinking about. When you have people who are crying out saying, help me grow, I have so many great ideas, I really want to lean in, I want to engage, I want to participate, I want to be part of the solution. Maybe they come with a solution that truly won't work, but could you engage that enthusiasm and idea, get them involved in the process, and they will learn through that work, okay, you know what, you're right. They'll come to their own conclusion. Okay, maybe this idea might not have worked as well, but now I have a better idea. And then you engage them in implementing that idea. Now you both win, because you've got a really incredibly engaged staff member who is on a trajectory of growth, who's going to stick with you to see this through. That is the absolute win on both sides.
Absolutely. I was just thinking that's a win-win, because how much does the organization or the health center or hospital, whatever, benefit from pouring into their staff or
exactly. And there's a lot of benefit to be had, because Like I said before, the end users are the ones who can school us all on how best to go about these processes. And if we don't engage them, they're going to become disengaged and go somewhere else where they can contribute. But you're going to miss out on that amazing enthusiasm and potential solutions to make things better.
Absolutely. And even starting out as a frontline person, quote unquote, and, working your way into leadership, that starts to dim, that frontline experience that you had. And especially in healthcare, the landscape is changing so rapidly that as a leader, you pretty much now have no idea of what it's like to be in the trenches. And that even becomes more important in my mind, to listen and to learn from them.
Yeah, you bring up an interesting point about leaders no longer being in the trenches. And I feel compelled to talk about that for just a minute, because I do think as a profession, we can get pretty judgy about, okay, you are in a role, you're no longer in my role, and I'm going to somehow vilify you for no longer being in my role. Well, they shouldn't be, because they are in a new role. I see it in academia where students will question, well, it's been 10 plus years since you've been in a bedside role. You're not really a nurse anymore. There is a culture of dismissiveness when it comes to those things, rather than celebrating the value and the work that goes into that particular role. I think what breaks down with that is when leaders don't intentionally build in time to stay connected to those other roles. I don't have to do it every day, but I'll tell you what, when there is a crisis on the unit, I better drop everything and roll up my sleeves and stand alongside. And I don't care if my role is mopping up the floor at the end.
Yes.
I will be in that room with you all, and I will debrief with you afterwards to say, how are you? This was handled well. I just wanted to let you know I saw what you did, and thank you for that work. That's a missed opportunity for leaders, but I hate the idea that we vilify leaders who have huge shoes to fill, a massive clipboard full of reefs of checklist items that they have to do on a daily basis. It is a difficult and complex job with a different set of responsibilities and criteria than maybe a bedside nurse would have. Neither is more important or less important than the other. But we have to honor both of those things and not set up a mindset where, leaders, they aren't in the trenches anymore. They don't know. That is a narrative I really would love to shift, and a mindset, because we need our leaders, and we need good, experienced leaders, and we need to raise them up to be honored for what they do and what they bring to the table.
Over the course of these 2 episodes, we've explored some of the biggest challenges facing today's nursing workforce with nurse leader and educator Heidi Sanborn. From the importance of designing healthcare systems with frontline nurses in mind, to the difficult transition many new nurses face during their first year in practice, this conversation highlights just how critical support, mentorship, and thoughtful leadership are to retaining the people who care for our communities. We've also talked about the gap between academic preparation and real-world clinical environments, and why stronger partnerships between nursing programs and healthcare organizations are essential to preparing nurses for the realities of modern healthcare. At the heart of it all is a simple idea. When we listen to nurses, involve them in decisions, and invest in their growth, we create systems where they can thrive, and where patients ultimately receive better care. A big thank you to Heidi Sanborn for sharing her insights and experience, and thanks to you for listening to The Exam Room. If you found this conversation valuable, be sure to subscribe and share it with colleagues who are working to strengthen the healthcare workforce. Until next time, take care.